My name is Nick Shammas. I'm at the Midwest Cardiovascular Research Foundation and the Unity Point Trinity Medical Center in Bettendorf, Iowa. This is my disclosure. We have a patient who have had ulcerations for the past several weeks. He's been through wound care management and there's no healing to his ulcer. So he has been referred by our wound care clinic for angiography and treatment. Just a background on this patient. This patient is 85-year-old. He's had chronic kidney disease. He's had peripheral vascular disease. He's had stents to his left common iliac artery. He has done well until recently when he noted resting pain as well as ulceration on the plantar aspect of his left great toe. So we have a 6 French sheath in the right common femoral artery. We are going to place a destination 65 centimeter sheath in the contralateral left SFA, and then we're going to be taking some pictures. All right, now we have the destination contralateral sheath in place. We did this with the use of a pigtail catheter and a woolly wire. The initial angiogram did not show obstructive disease of significance in the left femoral popliteal segment. So we're gonna go ahead and get the multi-purpose catheter all the way in. Very good. All right.
Go ahead.
Yep. All right, so take the wire out, please. And we can get the manifold, and let's just take a couple of pictures here. So we have pictures taken now to his left tibial vessels using DSA, and we can see very clearly that he has a subtotal occlusion of his mid-left anterior tibialis artery, and he has total occlusion of his left tibioperoneal trunk, peroneal and posterior tibialis. So let's go ahead and get the Spartacore wire is what we're going to be using to cross the lesion, and we are using also a CXI 014 crossing catheter. We have successfully crossed the lesion. We have the wire parked all the way into the dorsalis pedis on the left. Clearly there is a nice runoff dorsalis pedis, and that's one of the qualifications to be in the TOBA II below the knee. You have to have a reconstitution of the vessel. So let's go ahead and we're going to dilate the anterior tibialis at the lesion site. We're going to go ahead and choose a 3.5 millimeter balloon. We're going to dilate this for 60 seconds, and then we're going to evaluate for the presence of dissections and decide if this patient will qualify for the TOBA II below the knee study. You can look at the location of the disease following the balloon inflation. You can see a linear flap. It's very small, no dye is hanging, there's good flow. That is typically a type B dissection, based on the NH-LBI classification. So we see that there is a type B dissection, and the question is, would you tack this? Of course, many people would just simply say, this is non-flow limiting, let's leave it alone. We really do not know the importance of the various degree of dissection in below the knee vessels. It's very difficult to extrapolate data from the SFA to below the knee. So at this point in time, our practice is to have a low threshold to stent those patients with dissections, even the type B dissection. We want to give the patient the maximum time possible for patency of that vessel for wound healing, and we believe stabilizing the lesion may be of importance to do this. We're going to go ahead and enroll this patient in the TOBA II. He does have a dissection that would qualify for that study. There is an outer sheath that covers the tacks. There are 4 tacks in the system. So this is our catheter going over the wire at this point in time, and this is of course an over the wire system. Adam is going to be holding this wire, and we're going to advance this all the way to the area of the dissection. We're going to be advancing the Tack Endovascular System just beyond the dissection, and quite simply using a pin and pull technique, we will be delivering each tack separately, but you have to be careful not to pull too fast and deliver more than 1 tack at a time. So at this point in time, you loosen up the TUI. Now, if you look here closely, there are 4 marks on the shaft. Each one of those marks will indicate that you've delivered already one tack at a time. So every time your tui reach one mark, that means you've had one tack delivered. We've deployed the first tack. A little bit of a challenge with the patient moving a little bit. The nice thing about the Tack Endovascular System is the tack doesn't get released all the way till you reach its very proximal edge, till you get it exactly where you want it and align the gold mark with the area of the dissection. The dissection actually in the lesion is very focal, and we believe we caught the majority of the dissection with the tack. We don't see any dissection proximal to this. We're gonna probably just end up deploying one tack in this case. So again, for post-dilation, it's important that you go very slowly with your balloons so you don't dislodge the tack. We prefer that you use a balloon that has not been inflated before. This will make it a little easier for you. Okay, the balloon now is inflated and it will be inflated for 2 minutes. Afterwards, we're going to deflate the balloon, pull the balloon back, and we're going to take a picture and make sure that we have nice expansion of the tack and nice runoff all the way through the dorsalis pedis. This is our summary for the case. On the left part of the slide, you can see this is the original lesion. In the middle portion of the slide, you can see after balloon angioplasty and the type B dissection. And on the right side of the slide, you can see after the tack has been placed, the dissection has completely gone and the lumen looks essentially normal with barely any residual narrowing or any visible dissections.